Welcome to History of Retina's Leaders and Legends series. The purpose of these interviews is to capture first-hand stories from individuals with unique retinal insights of historical significance. Through these discussions, we hope to provide a fuller understanding of the evolution of the science and practice of retina through the lens of those who have lived it. It's a pleasure for me to be chatting today with Dr. Mark Blumenkranz. Mark is the H.U. Smead Professor Emeritus and co-director of the Ophthalmic Innovation Program at the Byers Eye Institute at Stanford University School of Medicine. In addition, Mark serves as Managing Director of Lagunitas Biosciences and is co-founder and president of the Collaborative Community on Ophthalmic Imaging Foundation. Mark started his retina career as a fellow and then faculty at the Bascom Palmer Eye Institute until 1985, when he was recruited away to Associated Retina Consultants in Royal Oak, Michigan. There he served as chief of the Vitreoretinal Surgery Service at the Kresge Eye Institute and was founder and director of the Retina Fellowship Program at William Beaumont Hospital. Mark has been an innovator of vitrectomy surgery techniques and clinical drug studies that have helped usher in the modern era of intravitreal surgical and drug therapy. He has published more than 175 papers in peer-reviewed journals and multiple book chapters and patents. In 1992, Mark transitioned to Stanford University, where he served in a variety of positions, culminating in his being named chair of the Department of Ophthalmology in 1997. And almost immediately he began working on the planning, funding, and construction of the Byers Eye Institute, of which he would become director. Mark is past president of multiple professional societies and has been the recipient of a multitude of awards and honors, such as the Stanford Medicine Albion Walter Hewitt Award, the AAO-AJO Edward Jackson Memorial Award Lecture, the Retina Society Gass Award Lecture, the Club Jules Ganan Wacker Prize Lecture, and the ASRS Gertrude Pyron Award Lecture, to name just a few. So Mark, thank you so much for being with me here today.
My pleasure.
And now, to put all of that into perspective, I want to start at the beginning of your story, with your childhood during the formative years. Shortly after you were born in Manhattan, New York in 1950, your parents moved your family, you and your siblings, to upstate New York, a little town called Binghamton. Tell me a little bit about your formative years, about your parents, and about being raised up there with your siblings.
Sure. Well, it's a town in upstate New York called the Southern Tier. It's sort of a mixed town. It was being deindustrialized, more of a college town, and it was a very nice place to grow up. My dad was a physician. My mom was at home raising the kids, and I had kind of a pretty normal, probably slightly boring childhood. I played sports. I liked music a lot. I think one thing I knew early on is that I was going to probably end up being a physician, because my father was, my grandfather was, and so that was just kind of a given.
You went to Brown University for college, medical school, and a master's program in biochemical pharmacology as part of an integrated 7-year undergrad med school program, including a master's degree as part of that program. And in our earlier conversation, you had mentioned to me that you pursued your interest in art and music during college, which coincided with the Vietnam War and the Woodstock Music Festival, a time during which, and I'm quoting you now, I adopted a persona consistent with a rock and roll musician. Please do go on and elaborate more about that.
When I arrived at Brown, it was still kind of a preppy New England place, and you had a blazer and a beanie, and everybody had short hair for the most part. It was fall of 1968, and things changed very, very dramatically during that next year. And by the end of that year, there was a lot of long hair on campus. On Woodstock occurred over the summer. People were protesting in the war, and it became, a very different place. So I would say, during my latter years as an undergraduate at the very beginning of medical school, it was very much the 60s and all the things that entailed. And I felt like I was part of it,
During medical school, you had dueling interests in general surgery and ophthalmology. But ophthalmology won out, leading to your residency at Stanford from 1976 to 1979. And while you were there, you were exposed to the pioneering research on argon laser photocoagulation being performed by doctors Chris Wang and Hunter Little, which ultimately inspired you to go into retina.
When I got to Stanford, at that point in time, as you mentioned, I was actually leaning more towards a career in general surgery or cardiac surgery. I wasn't exactly sure, but I had spent time at Bascom Palmer as a visiting medical student, and I really was entranced with all the possibilities. And one of the people I spent time with was Dick Tenzel, who was a very well-known oculoplastic surgeon. So I thought, I'll be able to combine my love of surgery and ophthalmology and be an ophthalmic plastic surgeon. Well, fast forward, I got to Palo Alto, and I rotated through the retina service, and Dr. Zwang was there and Dr. Little, and also Mike Marmer. And Zwang and Little were very instrumental in developing lasers for ophthalmic use. I used to tag along with them, and I realized that this was something very special. Lasers really were just coming of age, and they were still difficult to use. In fact, we had a xenon arc laser in the Department of Ophthalmology then, which was not a laser at all. It was a photocoagulator using visible light, and that was the standard of care up through the early 70s. And I realized that I thought it'd be much more challenging and interesting to me to be a retinal surgeon than an oculoplastic surgeon, so I decided to switch. And then I spent all my time tagging along, and they would give courses in the mid-70s that physicians would come from all over the country to see how to use a slit lamp laser. And so that was the beginning of my kind of love affair with lasers. And I wanted to learn everything I could about the physics, about the tissue interactions, and that carried through, as you know, for many years, many decades, really, and eventually led, if you fast forward about 40 years, to developing the Pascal laser. But it was really stemming back to those early years.
You did your Retina Fellowship at Bascom Palmer from 1979 to 1980. And Robert Mockemer did his pioneering vitrectomy surgery research there, but he departed for Duke in 1978, 1 year prior to your arrival. Do you have any recollection of your feelings about missing out on training with him? Was it a big deal, not such a big deal? Tell me about that.
Well, it was a really big deal because Mockemer was an incredibly influential and also charismatic person. By most accounts, people argue about these things, but for all practical purposes, he invented modern vitrectomy. And I had remembered meeting Mockemer and watching him operate when I was a visiting medical student. At that time, I guess it didn't impress me quite enough to not consider oculoplastic surgery, but I kept it in my mind. And of course, having seen Bascom Palmer, I just realized that it was kind of one of the epicenters. I won't say it was the only one. Certainly Mass Eye and Ear and Wilmer and some of the other programs were a big deal. But so when I was planning to train in retina, I thought I would certainly go to Miami and learn from Mockemer. And of course, there were other amazing people, Don Gast, and then he left. And so I had to make a decision about whether I went to Duke, where he'd only been about a year. Duke was a good program, but it wasn't the dominant place that it is today in retina or in ophthalmology. And it was kind of a hard decision because one of my fellow residents, Tom Freiberg, had actually wanted to do retina, and he went to Duke as a fellow. And I decided, well, I would go to Bascom Palmer because it had been, lots of great people, and so that was ultimately my choice, and it was a good choice for me personally, but it would have been a great thing to go to Duke too and work with Mockemer.
And so when you started your fellowship there, did you and the staff, right, because you were an extension of the staff, typically use the VISC now? Because he's gone, and so were people using the VISC, or were you being trained on the Ocutome, or a hybrid of both?
Well, it's a good question. So I was trained on both. When I got to Bascom Palmer as a fellow, most of the faculty at that point in time were still using the VISC-10 because there was still the very heavy influence of Robert Mockemer. He'd only been gone 2 years. But a couple of I'll quote, young faculty like Harry Flynn, my dear friend, and Gary Abrams, another dear friend, they were the younger guys, and they had come via other places. Gary had come from Milwaukee, and where Tom Auberg had trained him, and Harry had come from San Francisco with Wayne Fung, and they believed in multi-port smaller incision surgery. So I, being more closer in age to them than some of the other faculty, I gravitated towards that as well. And so I learned to use both. But when I started on the faculty a year later, I was exclusively using essentially multi-port microincisional surgery.
Well, how amazing to have been practicing at that time during that transition.
Well, one of the jobs of a retinal fellow was to assemble the VISC-10, which was actually non-trivial. And I remember once I kind of flubbed the assembly with George Blankenship, and George looked at me, and I think he thought, this guy will never be a surgeon. So I never made that mistake again. But I'd never seen a VISC-10 assembled before at that time, and so it was kind of an interesting period.
Now, in our previous discussions, you had mentioned that some of the attendings at Bascom Palmer would do surgery that would take an hour to an hour and a half, vitrectomy surgery, and others it could take 3 hours, 3.5 hours, 4 hours. Why was that? Was it the case selection? Was it the technique they were using? Or was it some people felt never create a tear and others were more tolerant of tears? Why the difference?
I was very influenced by surgically in terms of the techniques. I was particularly influenced, I would say, by Harry Flynn and by Gary Abrams. Gary was famously slow in the early years. He was a year out or 2 years out himself, and he was just a meticulous surgeon. And of course, when you're a junior faculty member there, you don't get the puckers and the fun stuff, the non-clearing vitreous hemorrhages. You get PVR and trauma. And those cases really were very tough, and nobody really thought you could fix PVR in those days. And so we would tackle them, and we actually pretty much figured out how to at least surgically reattach the retina intraoperatively. Now, the problem of reproliferation and redetachment was another matter. And I think that was the principal reason. But I think it taught me, and I tried to be very meticulous about my surgery, and I tried never to make a hole. I learned later to make retinotomies, of course, and became a devotee of that. So I think I took my time and tried to get the retinas attached, and I got reasonably well known around the community and eventually nationally for working on PVR and fixing them. And so by the time I got to Royal Oak, where I had very heavy surgical volumes, I had learned to be quite efficient. My surgical times were closer to an hour, hour and a half by that time. But I gravitated there over a period of 4 or 5 years as I developed my skills, and I look back on it, and I think that was the right way to approach it.
So you brought up the surgical management of PVR, but one of your interests in getting involved in lab research was the kind of cellular therapies for PVR. Tell us a little bit about your lab. You took over Mockimer's lab. You actually continued that when you went to ARC, which is a whole nother conversation of doing that in private practice. But let's start with your time at Bascom Palmer.
I look back at it, and it all seems natural in retrospect, but life's obviously lived prospectively, and I felt like I was getting the retinas on intraoperatively, taking my 2 or 3 or 4 hours, and then disappointment would hit, and they'd reproliferate, and they'd come back off, and then I'd operate again, and sometimes they'd stay on. But I realized that we needed better tools, not just for the intraoperative part of surgery, but the postoperative part of surgery. And that sort of took me back to when I was at Brown doing my graduate work in pharmacology. I was actually studying purine and pyrimidine metabolism, and I was particularly looking at cyclic AMP. So I really had that background in drug therapy, at least that form of drug therapy. And I realized that this was just proliferative disease, and 5-FU had been used, to treat cancer, but no one had ever really used the drug for any other reason. And I thought maybe we should look at all these drugs. And because it was fundamentally a proliferative disease, it was a benign proliferative disease, but it was a proliferative disease. And so I started working in the lab with tissue culture, and tissue culture wasn't all that commonly used for drug research at that particular point in time. So I had to go find someone in the Department of Cell Biology in Miami. And then we set up these micro-well assays where we tested every known antimetabolite for their ability to inhibit cells, and we tested them against fibroblast and also RPE cells and figured out which ones had the greatest inhibitory activity. And then I thought, well, that's great, but the retina is so sensitive. Obviously, if you put in a drug that's cytotoxic and you prevent recurrent PVR, but you destroy the retina, that's not great either. So then I went back and took the drugs that were most useful, that had the highest inhibitory potential, the lowest MI inhibitory potential, 50, and I tested them in rabbits and to see which ones were toxic. And after having done all that, it was actually very, very clear that there was a clear winner, and that was fluorouracil of all things. So it wasn't sort of a random choice of just pick an antimetabolite. It was one that, because that's that whole point of the therapeutic index, is the ratio between efficacy and toxicity. So we did that, and then we did the animal work, and we developed animal models of PVR. And then we showed that in animal models, 5-FU worked quite well. And so that really, and when I looked at it, I realized that, up to that point in time, if you wanted to work on the retina, you could use scleral buckles on the outside of the eye, and you could do vitrectomy, but there was no drug you could give to treat any retinal disease, maybe Daraprim for toxoplasmosis. And there was no field of retinal pharmacology. And I thought, well, how interesting. It's such an important tissue. And everybody's working with, knives and cutters and lasers, but nobody's working with drugs. And so it stimulated me to think maybe I could help create or expand a field of retinal pharmacology. So it started with PVR, but then it spread, obviously well beyond there over time. But it was really the beginnings of that, and it was sort of realizing that there are some things that require certain therapies, and you just cannot cross disciplines.
And another important thing that you studied in your lab was acute retinal necrosis. Tell us about that.
Yeah, I had gotten interested in infectious diseases of the retina while I was a Stanford resident. And aside from the laser, that was my other principal interest. And I'd written a number of papers, actually, about infections of the retina, particularly fungal infections. We had a big epidemic of coccidiomycosis in California while I was here. And I saw a whole bunch of patients that had ocular cocci involved the retina. So I wrote about it. And when I got to Miami, I was still interested. And my dear friend Bud Culbertson had come back. So we started sharing patients. And there had been one I think, case report of acute retinal necrosis came out of England, and then one or two. But we started seeing a number of these patients. And Bud and I would see them together. And it was just a horrible disease. In fact, it was really the most frightening disease prior to AIDS that you could imagine. And patients would come in that were perfectly healthy and had no predisposing risk factors, and they would develop whitening of the retina, and then the retina would detach and they would go blind. And there was ferocious debate about what was the cause of acute retinal necrosis. We had this one patient, and he had the disease, just terrible disease in one eye, and his other eye we're worried about. So we removed the eye because it was no light perception. We took it to the lab. We obtained pathology, and I remember this. I'll never forget this moment. I got the thin sections for the EM. We had it plated, and I was looking under the old J-OL electron microscope, and I looked in, and there were viral particles, and you could see these round, typical herpetic particles. And I realized I was the first person in the world that had seen these viral particles in this horrendous disease. We presented this, and there was this huge flurry of controversy and discussion. It wasn't really viral. It was really an autoimmune disease, and it had a lot of implications, because if it was autoimmune, you would treat with steroids, right? And there were some very prominent people who said, you got to treat this disease with steroids. And we said, this is a viral disease. You can't give steroids because it'll make it worse. And so we even sent the culottes around the country for people to look at it. And there was still debate, but I was convinced. So I thought, if it's viral, we've got to treat it. And so at that point, acyclovir hadn't been approved yet, but I knew it was being used by Burroughs Wellcome, and there was some literature on using it for for herpetic disease. So I called Burroughs Wellcome and I said, would you make this drug available to us, to use it, and they did, and so we started treating right at about the time acyclovir was coming out for herpes, and that led to the regimen that's been pretty much around. People are now using ganciclovir too, but and it was sort of a big deal, and so then we had come through, with first of all documenting that it was a viral disease, not an autoimmune disease, and secondly that there was actually a specific pharmacologic therapy that would be useful for it. So I felt like that was kind of an exciting, and we wrote a bunch of papers, and then we wrote papers on how do you fix the retinal reattachment, how do you reattach the retina with iron, and it just went on and on. But it was really a story that I saw play out in real time, and I just happened to be there at the time.
While at Bascom Palmer, you had an incredible opportunity to spend time with the legendary ophthalmic engineer and innovator, Jean-Marie Perel. Tell us a little bit about that.
Oh, well, Jean-Marie was just a real inspiration and a character. He was very Gallic, and he very expressive and very European and very creative. And then when Robert went to Duke, we all thought that Jean-Marie would go, but he didn't. He stayed behind. And I would wander down into his lab and say, I've had this idea about this or that, and what do you think? And I'll just mention one kind of crazy idea. Taking care of intraocular foreign bodies was really kind of a brutal experience in those days. We all had these massive magnets, electromagnets, and you'd stick it on the outside of the eye, and somebody would turn the switch and the current would go, and you were holding it with both hands because it was so heavy, and then this piece of metal would fly across the eye and come through the sclerotomy that you made to remove the metal. And I thought, that's crazy, why we should be able to do better than that. So I talked him into building an adapter to the magnet that was sort of a long, thin metal or iron extension that would fit through I think we decided it would go through a Visc incision, a little bit bigger incision, and then we screwed it on, and then because it was metallic and iron or stainless steel, I don't recall, when you turn the magnet on, the actual focal point of the charge or the field was at the tip of the magnet, so you could bring it very close. And then Jean-Marie said, well, there are these new rare earth metals. Why don't we put that on the end of a very small light handle? I said, good idea. And so he did that, and he came up with the particular rare earth that was used, and I helped with the design of the handle a little bit. And then we tried it on a couple of cases, and it worked really, really well. That became, as you know, the standard of care. And then later, when people started doing reattaching retinas usually as part of PBR surgery, but sometimes even without, people were commonly making these posterior retinotomies. This is in the era prior to the advent of perfluorocarbon liquids. And I really hated making posterior holes because I realized that you'd see proliferation around them. So I thought if we could find a way to drain a peripheral hole while filling the eye with air through a peripheral hole, wouldn't that be cool? So Jean-Marie and I developed together this, what people came to call the snake. And so we developed a little thumb screw, and we were able to advance a soft silicone. Nobody had ever used silicone on intraocular probes before. And then we advanced it through a peripheral hole to the back of the eye so that when you put the air in and the air moved from anterior to posterior, all the fluid was pushed posteriorly, and then it came out from the tip. And then we would then withdraw the snake, and you didn't have to make a posterior retinotomy. Harry Flynn and I wrote it up with Jean-Marie, and a lot of people refer to it as the Flynn cannula because Harry did a beautiful job writing it up and did most of the cases. I was just leaving Bascom Palmer to go to Royal Oak at that point in time, but it was the first of many collaborations with Harry and I worked together.
You were recruited away from Bascom Palmer to Associated Retina Consultants from 1985 to 1992, became chief of the Vitreoretinal Surgery Service at the Kresge Eye Institute, and you were the founder and director of the Vitreoretinal Fellowship Program at William Beaumont Hospital. Can you talk a little bit about those years? And in particular, I'm interested in the ability for you to maintain a lab actually while you were at ARC in private practice.
I thought, could it be possible to go off into a very large, well-regarded group that had people that I really, really cared a lot about, liked, knew very well, and sort of have a semi-academic lifestyle while being principally a clinician. And that was the task I set for myself when I left. Mike Tracy was there, and Mort Cox and Ray Margari were just wonderful, wonderful people. And Mike and I had become very close just from lecturing and going places. And I knew Mike was trying to build up the academic side of the practice in addition to the clinical trial side of the practice. So I said, well, if I come, can I have a lab? And they said, yeah, you can have a lab. I said, and can I bring my postdoc, who was with me at Bascom, who was a cell biologist, Mike Hartzler. I said, yeah, you can bring him. I said, well, do you think we could have a clinical fellowship? Because I really like training. They said, yeah, you can do that. And I said, well, what's not to like? That was kind of my thinking. And at the same time, I could really perfect my surgical skills because I still felt I had some more, improvement to do by doing more volume. And so those were great years.
So you left this private practice, Associated Retina Consultants, wonderful friends, wonderful environment in 1992 to go to Stanford. What led to that decision?
I just felt this really compelling need to return. And so it was really the pull of Stanford. And I do love Stanford as an institution and also as a concept. The idea that an organization can be so good in so many ways, in terms of the quality of its education, the quality of its thought leadership, the quality of life, living and working there, and really just being located inside Silicon Valley. And as a sailor, I liked sailing on San Francisco Bay too.
So you had an illustrious career at Stanford. What would you say was your most significant accomplishment, if you can choose one?
That's actually easy. It was building the Byers Eye Institute. When I left Stanford, I loved the institution then, but it was a very, very small department. I realized what a really great eye institute could do, and so and I decided I was going to make it my mission to do that. And a lot of other things happened along the way, but that's what I'm proudest of.
You are in a rare class of physicians who have made medical entrepreneurship look easy when it's not easy. You have not just dabbled, but you have truly excelled to the degree that by my count, you have founded, co-founded, or been a director of 15 entrepreneurial ventures, most of which have gone on to commercial success. What do you think has led to you becoming a serial entrepreneur?
It's a really good question. I never, ever imagined in my remotest dreams that I would be doing this. And it sort of grew, or I would say it grew organically. I realized that a lot of the research that got done never really resulted in necessarily a direct impact on a patient. I mean, it led to better understandings of disease, and diagnosis. But in reality, it was pretty hard to take something you'd worked on in the lab and put it in a patient and get them to work together. And I saw that it was starting to work in Silicon Valley. And so I said, I'm going to do that. And I started by just helping companies. And I would just go, they'd hire me or not even hire me. I just would say, you ought to do this, or you ought to try this or whatever. And then I said, and then sometimes they would, sometimes they wouldn't. And then I realized if I could sort of be part of the company but still be part of the university, I could be more effective. People would listen to me. That gave me that perch, really, to where the industry was interested in me as an academician and the academia was interested in me because I developed sort of a formula for either working with or, in fact, building companies that could commercialize. And now you look at it and you say, well, sure. I mean, that's definitely the thing to do. But there was really no, there was no textbook about how to do that, and I didn't have too many role models that had done it successfully.
After stepping down as chair of ophthalmology at Stanford, you became and remain co-director of the Stanford Ophthalmic Innovation Program. What are the goals of that program?
When I was stepping down, I knew I was going on sabbatical, and I wanted to keep busy, and I felt like I still had things to offer. So I used that sabbatical time to continue to work in innovation. And so we said, let's teach innovation. Now, I had worked with the Stanford Biodesign Program for 5 or 6 or 7 years before that, and I really subscribed to the principles of biodesign. First and foremost was meeting unmet needs. So I founded the incubator called Lagunitas Biosciences with the idea that we would build a great world-class laboratory. And so I did it with someone who eventually became the chairman of bioengineering at Stanford, Jennifer Cochran. And I recruited other people to be venture partners with me and a financial partner, and we raised a fund, essentially, what you could call a seed fund. And we decided that instead of having to pitch each and every new idea, we would either find companies, or better yet, we'd start the companies so that we didn't have to deal with the baggage of maybe some problems if there wasn't a suitable company already in the area that we liked. And so people would bounce back and forth. The fellows would bounce back and forth. They'd come over to the incubator for a day or two. That wasn't where they spent their time. They spent their time at Stanford prototyping, and we'd position them in companies, young startup companies, or even more serious companies. And as I look back now on all of that activity, it looks like it's more or less working pretty well.
Last question. You have, by any measure, had a truly spectacular career. Is there any particular experience that you feel has profoundly impacted that career?
About 20 years ago, actually, this year, one of my children developed a very, very serious life-threatening illness. And we worked through it, and it ended very happily. The problem was resolved. But for a period of about 6 months, I didn't know what was going to happen. And every morning I woke up and I worried so much about it. It's still emotional to me now. And I realized that was really what was most important to me, was my family and my welfare. So I think that's probably the thing that has changed me most and has driven me, that I didn't necessarily anticipate or see coming. But I think it really was a wake-up call to me to really prioritize everything.
You have had a remarkable story. Thanks for sharing it with us today.
Thank you. It's been a pleasure.